Hi there, everyone. It's my last talk you'll be pleased to hear. And the first thing to say is I believe there are 4 phases to rehab, as I'll show you. Times are really only a guide, and I don't use a time-based rehab program. I prefer the isokinetic concept of achievement-based progression. In other words, when an athlete has successfully completed one phase, they move on to the next one. The first phase is the inflammatory one, and this lasts about 3 weeks. You've got to get the knee straight. And to do that, you need to give good analgesia. The patient can't do this if they're in pain. You've also got to restore a good isometric quad contraction. Bertrand's produced some excellent research on this. And to help free up the fat pad, I want patellomobilization. The fat pad's the source of all trouble, really, and it will block extension. We reduce swelling in the usual way with ice, compression, etc. But also muscle activity is very important, and I'm keen on getting the limb moving normally. Most of my patients are full weight bearing, and they'll have crutches simply for protection for 2 or 3 weeks. The only time I restrict weight bearing is if they have a radial or root tear of a meniscus, and almost never do I brace a simple ACL reconstruction, even with complex meniscus surgery. Second phase is really the healing phase, and during this we restore flexion up to full at 12 weeks. We've got to get flexible in the posterior muscular tendinous units, and we've got to restore strength to some degree. Most of the quadriceps work will be closed chain. In other words, the foot is on a platform such as a leg press or on the ground for a squat or a wall slide. There's no restriction in the actual weight, but I like the movements to be slow and very controlled. I do believe in doing open chain exercises. They're very valuable, but I don't allow them in the last 30 degrees of extension, as that will pull the tibia forward. We use hamstrings without restriction, as pain allows if a hamstring graft has been used. And I work hard on the trunk and pelvic muscles, the so-called core. We also do some basic balance work to restore muscle patterning. We can use a bike at 4 to 6 weeks and swim at 6 weeks. At 12 weeks from surgery, I meet the patient again. I want to see very little swelling or none, ideally. I want symmetric active extension, unless they're a big hyperextension extender, where I quite like them to have lost a little bit of that excess. I want a decent single leg squat, and I want a good ACL graft when I examine it. Now, isokinetic testing is often popular at 12 weeks, but I must say I'm not particularly keen. It's pretty aggressive on the knee, and I've seen players injured by it, and if we can avoid it, I like to do so, or at least delay it maybe till 16 weeks. The third phase really starts at 12 weeks, and that's restoring the athlete. And they become athletic again through strength work, which involves no restrictions. You add complexity, more ballistic activity, the muscle, in other words, quicker. And you've got to re-establish good quadriceps control in terms of the eccentric phase. So eccentric strength gives you shock absorbency. And we add in much more complexity to the balance and proprioceptive work with plyometric drills. But you do have to be careful, particularly with the older athletes who may have some patellofemoral damage. You can easily overload using plyometrics. Sometimes we have to cut right back and just rely on the on-pitch sport-specific work to give plyometric stresses to the knee. And also, of course, we need the patient to be aerobically fit. One of the questions I'm always asked, when can we start running? Well, the simple answer is when you have a symmetric, good quality single leg squat, because effectively shock absorbency during running occurs in a single leg squat. If it's no good, when you test it, they won't be able to shock absorb and they'll get pain or swelling. Once they're able to run properly, they can move on to sport-specific training, and then a graded exposure to match play skills, and then a return to full training. And then about a month after that, back to match play. And again, that needs to be controlled and graded. They can't do 90 minutes immediately. And in terms of return to play, I'm happy to allow that as a minimum of 6 months, although the reality is it's more like 8 months. They've got no effusion. The player's confident, although you've got to be a bit careful with that. They've proven that they're aerobically fit. And the magical thing is symmetry. Now, we have a whole battery of tests we use. None of them on their own is green light or red light. And I find it quite a depressing topic. We've not worked out what's best. I think we will in time. But we do need to reestablish symmetry and be well within 10% of the other side. And then the phase 4 is perhaps me trying to be clever. And really, it's to point out that the full optimal recovery doesn't occur until around 2 years from surgery. And during that period, the knee is at risk of graft re-rupture. And so the athlete needs to carry on with all their maintenance work, proprioceptive drills, etc. And the final physiotherapy to restore as normal knee as we can, although I think it never is fully normal, is to play their sport. But we have to accept there's risk with that. Thank you very much indeed.